Hi everyone, welcome to Concept in Medicine. In today's tutorial, we are going to be looking at diabetes mellitus. We are going to look at how to distinguish between type 1 diabetes mellitus and type 2 diabetes mellitus. So first of all, we are going to define type 1 diabetes mellitus and type 2 diabetes mellitus. Then after that, we'll delve in to look at the differences between the two in a tabular format. So let's have a look at that. Type 1 diabetes mellitus is defined as a clinical condition characterized by chronic hyperglycemia resulting from autoimmune destruction of the beta cells of the islet of Langerhans, leading to an absolute insulin deficiency. That will make it for a type 1 diabetes mellitus. What of the type 2 diabetes mellitus? For the type 2 diabetes mellitus, it is defined as a clinical condition also characterized by chronic hyperglycemia resulting from a combination of resistance to insulin action, inadequate insulin production, and inappropriate or excessive glucagon secretion. And as a result, would lead to a relative insulin deficiency in that regards. So that will make it for a definition for a type 2 diabetes mellitus. Now let's move ahead and look at the differences between the type 1 and the type 2 diabetes mellitus using various features. So we are going to start with the first one. That will be the clinical. For the type 1 diabetes mellitus, is characterized by polyphagia, that is excessive eating, polydipsia, that's increased thirst, that will lead to excessive drinking of water, polyuria, that means that the patient will be urinating a lot. And if you take polyphagia, for example, it has to do with what? A substance or a peptide we call amylin. And amylin is a satiety agent. What does it do? Amylin slows down gastric emptying, and by so doing, it decreases postprandial glucagon secretion. And you should know that this substance or protein is produced by the beta cells of the islet of Langerhans. So in type 1 diabetes mellitus, where the beta cells are being destroyed by autoimmune causes, then definitely amylin secretion would also be what? Low. And in that case, the patient with type 1 diabetes mellitus will not have any satiety control. Hence, he or she will continue eating without regulation. And that is what we call polyphagia. With regards to the polyuria and polydipsia, we will say that both of them are due to osmotic diuresis. And what do we mean by osmotic diuresis? Then we should ask, in diabetes mellitus in general, what happens? You realize that the plasma glucose or serum glucose levels are high. And you should know that glucose has a high osmotic potential. It creates an osmotic gradient where water is drawn to wherever the glucose is. And by so doing, if there is excess amount of glucose in circulation or in the blood, it is sent to the kidney where it will be excreted. And as glucose is being excreted, it draws along with it what? A lot of water, leading to the diuresis. And that mechanism is what we call osmotic diuresis. And if a lot of water is being lost, then the patient will start having what? Thirst. And with regards to the increased thirst, it means that the subpharyngeal organ, which is located at the interventricular foramina, located between the lateral ventricle and the third ventricle, will ensure that there is a monosynaptic and a polysynaptic communication or connection with the supraoptic and the paraventricular nucleus of the hypothalamus, and that is going to stimulate the thirst. And if the thirst is stimulated, then definitely the patient will be taking in a lot of water. I believe that makes sense to you. Then the next thing is there will be unexplained weight loss. Then again, another thing we can think of is a family history or personal history of autoimmune diseases. Yes, because we said with regards to the definition, we said that diabetes mellitus type 1 has to do with an autoimmune destruction of the beta cells of the islet of Langerhans. So in that case, we should be having an autoimmune disease as an underlying cause. And the next one is for type 1 diabetes mellitus, patients are usually slim. They are usually slim. And finally, type 1 diabetes mellitus usually has an adolescent age of onset. Then the question goes, who is an adolescent? 10 to 19 years of age, according to the WHO definition. Now, let's move ahead and look at the type 2 diabetes mellitus with regards to the clinical features. So, for type 2 diabetes mellitus, usually they progress asymptomatically. They are usually asymptomatic. They are usually asymptomatic, meaning that they do not present with symptoms. Or if they are going to present with anything at all, they will come along with complications. Example is the silent MI. So then again, for type 2 diabetes mellitus, patients are usually obese. They are usually obese, meaning if you are looking at the BMI, body mass index, they would definitely be greater than or equal to 30 kilogram per meter square. And finally, type 2 diabetes mellitus usually has an adult age of onset, meaning when we say that, it means that it's not only in the adult age, but mostly it's going to be in the adult age. When we are completing this particular session, we would end with what if they present in the opposite age. That will be if type 2 diabetes mellitus, we are saying that usually has an adult age of onset. What if it is happening in the adolescent? And the same thing applies to the type 1. What if they are occurring in the adult? How will you call them? We'll get there and we'll talk about it. Now let's look at the biochemical features, how it will be different in type 1 diabetes mellitus as compared to type 2 diabetes mellitus. So for biochemically, we'll see that the type 1 diabetes mellitus is characterized by persistent hyperglycemia, unresponsive to lifestyle modifications and oral hypoglycemic agents, meaning that if the patient is taking lifestyle modifications such as diet, exercise, and weight loss, there will not be any significant improvement in the glucose levels. And also with the oral hypoglycemic agent, which we'll be looking at later, you will not have significant improvements. Then again, for type 1 diabetes mellitus, the serum C-PEPTIDE levels are going to be low. Why are we saying that? Before you produce insulin, insulin will be produced as a result of the cleavage of proinsulin. In that case, when proinsulin is broken, that is cleaved, you have the insulin units on one side and the C-peptide, that is the connecting peptides, also on the other side. It tells you that the C-peptide, which is the connecting peptide, is what joins the insulin unit together, and that compound is what we call proinsulin. So it tells you that when insulin is being produced, C-peptides would also be produced. So in the case where insulin is not being produced, then C-peptides would also not be produced. So in that case, we are saying that the serum connecting peptide levels will be low in type 1 diabetes mellitus. And then type 1 diabetes mellitus is characterized by ketosis, as that is who manifests as what ketoacidosis and what ketonuria. In our subsequent topics, in our subsequent lesson, we'll be looking at pathophysiology of diabetes ketoacidosis, where we would delve deeper into how the ketosis comes about in type 1 diabetes mellitus majorly. Now let's look at the type 2 diabetes mellitus, the biochemical features. So for the type 2 diabetes mellitus, for them, they will respond in a way to lifestyle modifications such as diet, weight loss, exercise, and also to oral hypoglycemic agents. Then again, for type 2 diabetes mellitus, because it does not have to do with the destruction of beta cells, the serum C-peptide levels, that is serum connecting peptide levels, are usually normal or maybe slightly, a bit slightly reduced, not as significant as compared to type 1 diabetes mellitus. Then finally, the are usually not associated with ketosis, which will manifest as ketoacidosis and ketonuria. It doesn't mean that it cannot be there. Yes, it can be there to an insignificant level, but usually ketosis is what? Absent. Now, let's talk about the next parameter, that will be the immunological. For type 1 diabetes mellitus, it is characterized by the presence of autoantibodies, such as the islet cell antibodies and also the anti-glutamic acid decarboxylase antibodies. Then again, you should know that the type 1 diabetes mellitus is characterized by the presence of the human leukocyte antigen, specifically the DR3 and the DR4. Then when we look at the immunological features of type 2 diabetes mellitus, you will notice that the autoantibodies are not present, they are absent, and also they have no human leukocyte antigen association. Then again, looking at the genetic features, then we will say that if you take the concordance in identical twins for type 1 diabetes mellitus, it is approximated at 30%, which indicates an environmental influence. But if you go to the type 2 diabetes mellitus, the concordance in identical twins is approximated or is equivalent or is greater than or equal to 80%, indicating or showing a stronger genetic influence. Then finally, as I said, type 1 diabetes mellitus does not only have an adolescent age of onset, it may also occur in the adult. It's happening in the adult, we'll call that the latent autoimmune diabetes in the adult. And you should know that the latent autoimmune diabetes in the adult has a slower progression. That is why the features are realized later on in life. By then, the patient would have become an adult. That is why we call it latent autoimmune diabetes in adults, meaning it is a form of type 1 diabetes mellitus having its onset in the adult age. What of type 2 diabetes mellitus? For the type 2 diabetes mellitus, it can also have an adolescent age of onset to a minor extent. And if you are having a type 2 diabetes mellitus having an onset in the younger age, then we'll call that the maturity onset diabetes of the young. And for the maturity onset diabetes of the young, it is considered as a rare autosomal dominant form of type 2 diabetes mellitus, which has an adolescent age of onset. I believe we've made a good understanding sitting through this lesson. Thank you very much for sitting through the lesson. Kindly make sure to subscribe, like, share, and also comment the concept you would like to see in my next tutorial session. My name is Dr. Adele, and this is Concept in Medicine. Bye-bye.